Hello, my name is Efram Ellenbogen. Welcome to my research proposal presentation, in which we'll be exploring the effectiveness of quality assurance chart review audits on adverse events for patients in clinical practice of Ontario paramedics. So we will arrive at the summary by discussing the who, what, where, why, and how of this problem, which includes a literature review, study design. We will discuss some ethical considerations in performing this research, as well as some challenges. So we'll start off by covering what, as in what is the problem. My area of interest is whether or not current quality assurance chart review processes alter the paramedic clinical practice in Ontario and ultimately reduce adverse events in patient care. This exploratory research aims to test the sensitivity and specificity of quality improvement programs, as well as the validity of current quality assurance chart review programs. So let's start off with a bit of background and discuss who this is a problem for. First and foremost, this is a problem for patients. Quality assurance is intended to help establish policy, guidelines, and propagate improvements under the guise of providing health outcomes that are in line with current best practice and target a specific population. However, paramedic field work requires expeditious decision-making involving critically ill and injured patients with limited consultation. This affects patient morbidity and mortality. Succinctly, there is a higher rate of clinical variance in the paramedic field, resulting in a 14% negative outcome rate for patients. Secondarily, this is a problem for paramedics and paramedic services. There's a lack of research to prove the validity of current QA programs. This is due to factors such as varying skills and scope, practice across regions and services in Ontario, which hinders the development of industry best practice. Likewise, this is compounded by a lack of data sharing between quality assurance departments. Paramedic services have a mandate to deliver quality care at lower costs, as well as drive improvements. Yet the current measures are not based on relevant performance indicators, which ultimately means there is no metric by which to measure the quality of care the paramedic services are mandated to deliver. So let's discuss where this is a problem. The paramedic skill set and scope of practice has displayed exponential growth in the last 15 to 20 years. Yearly updates to skill sets, guidelines, and medications that can be delivered at scene highlights the dynamic way in which a patient may interact or have an adverse event with the paramedic. This is compounded by the newest milieus of paramedic practice, including at-home visits by community paramedics and advanced care paramedics working in Indigenous community nursing stations to facilitate increased access to care. With this expanded scope comes a need for an increased level of quality assurance and review. So let's further expand upon why this is a problem by talking about the literature review. As is evident, a literature review covering the last 10 years of quality assurance research for paramedics in Canada reveals a lack of information. These 5 articles will be reviewed in order to identify the most current knowledge gap. Tavares et al. In 2021 state that increased paramedic scope of practice is an opportunity for increased justice in the Canadian healthcare system. Yet Canada persists in lagging behind in creating a research agenda in order to drive quality improvements. Tavares et al. Identify these thematic issues in quality improvement in paramedicine. Current QA measures are based on mostly response times or metrics that do not reflect the quality of care. The varied and numerous system models means that there are various standards of care, as well as various quality assurance models. There's a lack of efficacy in these models in detecting change, preventing harm, or altering paramedic clinical practice. And finally, organizational, structural, and cultural barriers hinder development of evidence-based, specific, and effective quality assurance programs. In 2018, Boyle and Keeps studied over a decade's worth of data from the Royal College of Medicine concerning quality assurance review processes. They've defined quality assurance reviews as a standard quality assurance metric. This study is extensive and lengthy, yet the findings are associated with doctors and nurses, not paramedics, so there may be some issues with generalizability in the medical field. However, overall, the Royal College of Medicine and Boyle and Keep summarized that the QA model is neither effective nor efficient at preventing adverse outcomes, especially when juxtaposed with modern quality improvement programs. Furthermore, it is an inefficient use of resources, as quality assurance departments tend to use a lot of money, manpower, and effort in performing their task. So what this really means is that it serves the agenda of regulators, as in it's monitoring documentation rather than clinical performance. So consideration is needed respecting the effort, cost, and the outcomes of this current system when juxtaposed with adverse events for patients. Eaton, Williams, Mould, Magnuson in 2020 identified the need for structured and effective paramedic feedback. The current system provides scant regular feedback and guidance, which limits the development of skills. Furthermore, quality assurance review programs rely heavily on written feedback, which limits engagement and isolates frontline paramedics. This is compounded by the previously discussed onerous nature of QA programs, which limits the ability of those in the department for follow-up. Lastly, paramedics have little opportunity for self-reflective learning due to many factors including workload, lack of training in self-reflective practice, and barriers, which we will discuss next. Meanwhile, Sinclair et al. Have discovered that self-reporting is a highly sensitive technique in the paramedic field for reporting adverse events for patients. However, there are some major cultural barriers for self-reporting for paramedics, which include fear of reprimand, suspension, termination, or revocation of their certification or licensing. Fear-based barriers represent a significant challenge in understanding CPG compliance, patient care variances, and the facilitation of professional cultural change. They espouse the need for a structured and evidence-based approach to feedback in order to generate authentic data and enhance the quality of care in the paramedic field. There exists a modern framework by which to evaluate the quality and efficacy of care delivered by paramedics. Ebbs et al. Designed a study in order to address the issue that quality improvement in medicine has historically been challenging to quantify, and developed quality measurements and improvement criteria for regional paramedic service in New South Wales, Australia. The basis of this study was key performance indicators based on pathological categories we will explore shortly. These criteria generate relevant data about the quality of healthcare decision-making specific to the paramedic field of practice. Through this innovative quality improvement program, they implemented strategies for awareness, engagement, and education, resulting in a change in paramedic practice and statistically significant improvements in quality based on key performance indicators. While the study proves that there is efficacy in QI programs for paramedics, there is a lack of generalizability with dissimilar guidelines, management, and licensing than in Ontario's paramedic services, as well as different patient demography and service delivery models. So now that we've covered the knowledge gap, let's talk about how we're going to address this gap with our research hypothesis. My alternative hypothesis is that quality assurance chart reviews do not reduce clinical adverse events based on the key performance indicators that were developed by Ebbs et al. We'll try to prove the alternative hypothesis with our exposure variable quality improvement education programs. Let's talk about how we're going to accomplish this through our research goals. Our primary research goal is to reduce adverse events based on KPI, quality improvement education programs. A Delphi study by Suisse-Sardina et al. Identified key clinical indicators of quality healthcare. There are 5 categories of KPI under this guise. We have acute myocardial infarction, cerebrovascular accident and transient ischemic attack, chronic obstructive pulmonary disorder, diabetes mellitus, and mental health disorders. This represents the breadth of common clinical conditions encountered by paramedics on a daily basis. Hence, they represent reliable and valid metrics by which to measure the quality and outcomes for patients. These metrics also focus on clinically relevant outcomes rather than all possible patient interactions, meaning benign occurrences are discounted and documentation errors will not become the focus of quality review and assurance. Some secondary goals include targeting paramedic performance and clinical skills, as well as facilitating effective and easy-to-use clinical practice guidelines. So our study is a randomized controlled trial that will be analytic and quantitative in nature. We are randomizing this trial in order to reduce bias, and it is the gold standard. And we will stratify the results by level of training for the paramedic, and we'll discuss this a little further under recruitment and challenges. And we will perform pre-test and post-test adverse event rates analysis on both the control and exposure group. These tests will be based upon variances defined by current QA review processes, as well as the KPI developed by Ebbs et al. In New South Wales. We will also follow up with accepting facilities in order to cross-check the classifications and outcomes for adverse events brought forth during the QA review process. This is a medical legal obligation to uphold the advanced life support patient care standards of the Ministry of Health of Ontario. So we will study variances based upon a combination of factors. Let's discuss the variables in this study. The QI programs will be structured around key performance indicators, patient categories, and consistently identified clinical variances associated with adverse events and chart reviews. The chart review involves sending a request for written explanation in relation to clinical variances identified by documentation only. So if you want to think about it in another way, the exposure group will be proactively educated, whereas the control group will be retroactively educated. The outcome will be the overall rate of adverse events when we compare the pre and post tests, which are based primarily on KPI patient categories. Talk about inclusion and exclusion criteria. Inclusion criteria will be for all levels of care paramedic in Ontario, primary, advanced, and critical care. They must be certified by the Ministry of Health and Long-Term Care with at least an MCA. They have to be currently active with a regional-based hospital program, which means they have to be employed, and they must have work experience for over 1,500 hours, which is approximately a year. They must have also interacted with a QA process at least once, which is defined as either a documentation clarification request, documentation amendment request, remedial process, or a deactivation for quality assurance issues. The exclusion will obviously be participants with less than 1,500 hours, as they may lack exposure with the process. Likewise, if they are employed by private employers such as medical event coverage or private transfer services, they are actually licensed under a different branch of the Ministry of Health and Long-Term Care and do not employ many symptom relief or skill sets as we see in the paramedic practice. Also, if they are currently employed as a supervisor, manager, or worker for a quality assurance and development program, as well as employed contractually by the Ministry of Health and Long-Term Care for paramedic service audits, they will also be excluded due to possible response bias from the nature of their work and experience. Our recruitment strategies encompass the goal of a minimum enrollment of 1,500 paramedics from across various rural and urban services in Ontario. We will achieve this through emailing the directors of paramedic services in order for them to disseminate information to paramedics, and paramedics can elect and be self-enrolled. Furthermore, we will recruit using social media, whereby a link to a survey can be provided in which the recruits will be sent a questionnaire to better assess their eligibility, and this is in order to capture paramedics who are certified and active but work as a self-contracted in the province of Ontario. Some of the ethical issues to consider in this study will be the inclusion of vulnerable populations. Our recruitment policy of paramedics who are certified and active with the Regional Base Hospital program compels them to have had an OPP vulnerable sector check prior to any patient interactions, thereby mitigating this issue. The use of personal health information means that considerations must be made for TCP-S2 in regards to confidentiality, privacy, consent, and data handling. Identifiable patient data will be needed to correlate the paramedic call report and hospital charts in order to cross-check adverse event identification. We plan on gaining ethical approval without patient consent by encrypting the data and anonymizing published results. Furthermore, the nature of emergency medical calls would prove impractical to obtain patient consent for induction into the study due to the nature of expeditious care provided by paramedics. Furthermore, the need to adhere to current CPGs may result in patients in the study being exposed to non-current care modalities or having patients' wishes conflict with the CPGs under the purview of patient-centered care. Overall, this may mean that there will be adverse events identified under the chart review process that aren't truly adverse events. This will be excluded from our data in the study. Some study challenges includes the different levels of guidelines used by primary, advanced, and critical care paramedics. Hence why we will be stratifying the results in our data. We also need to guarantee the anonymity and protection from retribution to paramedics. As discussed earlier, the cultural fear of reprimand is quite strong in the paramedic frontline crews, and we need to make sure that they feel safe to engage in the study. We will anonymize them through the chart review process to mitigate this fear. Software compatibility issues will be addressed by the recruitment of a software analyst in order to collate the data into a homogenized data format. A lack of generalizability is the reason we want 1,500 participants minimum across a broad range of paramedic services from rural to urban. Statistical analysis is used in this study will include pre- and post-test variant rates to establish testing data baseline using the KPI patient categories. A chi-squared statistical analysis of the dichotomous categorical variables will be used in order to infer an odds ratio to demonstrate whether quality improvement or quality assurance programs result in lower variance rates. Intention to treat will be used to reduce bias and can compensate for operational, medical, and staffing needs typical with the paramedic service. In summary, this study is important as quality improvement in the paramedic field requires research, evidence, frontline worker engagement in order to attain true quality patient care. Thank you very much for watching my study proposal video, and have a nice day.